All right, it's 10 a.m. by my watch. So we'll go ahead and get started. Good morning, everyone. Thanks for joining us today. I'm Aaron Lamb, your host of the Informed Prostate Cancer Support Group meeting. And there we go. While the pandemic may be on its last legs, we are still awaiting notification that we can return to the SBP auditorium. So until then, with the effort of myself and John Tassi and everyone else, we're going to continue to have the information via live stream on our regular meeting dates, being the third Saturday of each month. But we're getting closer and closer to getting back in person. We're really looking forward to it, and I know a lot of you out there are. The principals of our organization are Bill Lewis, our president, who also does our newsletter summaries, Jean Van Vliet, a director and treasurer, Steve Pendergast, our secretary and newsletter editor, Bill Manning, our director and videographer, myself, Aaron Lamb, director and facilitator, and John Tassi, our webmaster. And of course, there's you, a growing membership of over 900 people, and everyone is a volunteer. You can be too. I'm sure that you received in the last few months our new trifold brochure that Bill and Jean especially worked hard on putting together and updating. If you, I hope you've passed those out to either people that you know of that are in need of joining the group, or perhaps a doctor's office that's allowing you to advertise for us there. If you need more of those, you can always contact Bill or Jean on the hotline numbers or the website. And we also have the prostate cancer bumper stickers, window stickers, and I hope that you've started to see those around town. But those are, I think we send out one to everybody as well, and we can certainly send out more. We're also several months into the grocery receipt advertisement. These would be on the back side of those long grocery store receipts, I believe at various Vonses across the county. We're very interested in knowing if you've seen those. Okay. And as our support to you, we have our website, www.ipcsg.org. There you can find just an absolute wealth of information, links to the upcoming live streams, the meeting summaries, the newsletters, and the advertisement for what the next meeting will be. It's a great resource for people recently diagnosed with cancer, as well as people looking for continued treatment as well. I highly recommend anybody that has not looked at that website to check it out today, review it often. And like I said, those newsletters are fantastic. They contain write-ups of the previous meetings, as well as a lot of new medical information. Really the state-of-the-art standard of care type of thing. We also have, as our support to you, hotline numbers that you can call. These are especially important for people recently diagnosed with prostate cancer. You can contact Jean or Bill at the phone numbers that you see there. Those numbers are also available on the website. They can put you in touch with other people, other members that can answer any questions that they themselves can't. Really useful to take advantage of. And we also have Sharon, who has volunteered to talk with women, family, and caregivers. As stressful as it is for us men with recent diagnoses and ongoing treatment requirements, it can be just as much of a struggle for everybody else around us. And so Sharon's been very nice to offer to give some advice to those people as well. And we do need volunteers. We need people to help recruit and schedule speakers. Also, a couple times a year, we've had roundtables where members share their experience. So we're always interested in finding new people willing to share their stories, as well as to take hotline calls. And thank you. I know that since the roundtable, we have had more people offering to do the hotline calls. So thank you very much for doing that. We encourage more people to help out as well. And you can always contact us through the website. There's a way to send us an email, or through the hotline number that I believe is either Bill or Jean's number right there. So our support group purpose is we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not be a substitute for your own medical counsel. And we do need your support. We are a 501c3 nonprofit organization, and so that means donations are tax deductible. There's no medical or religious affiliations. And during the coronavirus pandemic, we are video streaming our meetings, but our costs remain very much the same. There is the cost for setting up the Zoom webinar, for our website, for mailing out the brochures and the newsletters for those of you that get them in the mail. And so we very much appreciate donations. You can do that online via PayPal or by sending a check to the address that you see there. And that address is also available on the website. For today, we have Dr. Michael Hsieh, Professor of Urology and Director of UCSD's Men's Health. He specializes in male fertility and men's health. He treats men with sexual dysfunction, including low testosterone, erectile dysfunction, and Peyronie's disease. He also treats male infertility, including men with ejaculatory disorder, hormone imbalance, sperm production impairment, cancer, and genetic causes of infertility. In collaboration with doctors at Moore's Cancer Center, he focuses on enabling male patients with cancer to preserve their fertility options before cancer therapy. He also helps cancer survivors preserve or regain their sexual function after they receive cancer treatment that has sexual side effects. Unfortunately, due to some scheduling conflicts, we had to pre-record the interview with Dr. Hsieh. I hope you continue to tune in to watch it. We won't have a live Q&A session at the end of this, but if you submit your questions through the IPCSG website, we can forward them to Dr. Hsieh to get a response. And with that, here's the interview. Thank you.
All right, great. So for those of you that don't know me, my name is Mike Hsieh. I'm a urologist at UCSD, and I'm super excited to be invited by you guys to give a talk about prostate cancer survivorship. And you guys are always a great group, and you do a lot of great work serving as resources for our local and also long distance prostate cancer survivors. Unfortunately, due to a scheduling conflict, I could not meet with you guys in person this weekend. So this is the best thing that we can kind of put together. So for the group for now, and I'm happy to come back for an in-person in the future if you guys have more questions. So, and then we'll get started. So prostate cancer, as all of you know now, it's the most common non-skin cancer in America. Approximately 1 in 7 men will be diagnosed with prostate cancer. And to date, there's around 3 million US men count themselves as prostate cancer survivors. There's 3 goals to prostate cancer treatment. One is cancer control. Second is continence or urinary control. We know that approximately 1 out of 10 patients will experience some type of stress urinary incontinence longer than 12 months after surgery. And this should probably also be expanded to bowel control as well. We know that there can be changes in bowel movements and bowel habits after surgery and radiation treatment. So the goal is really try to minimize the side effect of urinary and bowel habits. Lastly, sexual function. We know that this is a known side effect of all forms of treatment, and that about approximately 70% of the guys have some degrees of potency at 24 months after surgery. And men are more likely to have an adequate erection for intercourse at 2 and 5 years after surgery than radiation treatment. So these are the priorities, and we're not going to compromise one for the others. So, and we will kind of address, as a urologist, I will be here to talk to you about, what to expect and what can we do to help you with urinary and sexual function. So this is the worldwide incidence of prostate cancer. The highest rate of prostate cancer is in Australia, New Zealand, and North America, while the lowest rate is in Asia. And the reported incidence of post-prostatectomy incontinence is anywhere from 9 to 16%. So there's many types of urinary incontinence or urine leakage problems. The most common one that affects the prostate cancer patients who undergo radical prostatectomy is stress urinary incontinence. That's usually occurs when they cough or sneeze. So with exertion, whether they're lifting something, picking something up from the floor, picking up their grandchildren, or that's when they leak. In people that have more radiation treatments, they have more of an urge type of incontinence that usually has to do with bladder that's overactive, from the side effect of surgery, and they end up having a little bit of the gotta go feeling, and then that urge is so strong they don't always make it back. They don't always make it to the bathroom in time to pee. Therefore, they leak. And not uncommonly, I see guys with both. They could leak when they have urge, and they also leak with coughing and sneezing. So these are the versions of urinary problems that we can see after prostate cancer treatment. So the major cause of male urinary leakage or incontinence is obviously, like I mentioned, surgery. Radical prostatectomy, when we remove people's prostate, that's one of the known complications, and that's our second goal of trying to achieve a good outcome for you all. Other things that can relate to other pelvic surgery, we see this in people with colon rectal cancer as well, people with spinal cord injuries or trauma to the back or pelvis, enlargement of the prostate, people are born with certain birth defects, or people have stroke or any other neurological or anatomical problem. We also see a leakage problem in men. So before we talk about how to treat it, let's talk about exactly what happens. Okay, so this is a diagram try to give us a little bit of a cartoon of what happens. So you can see in picture number 1, there's a cancer spot within the prostate gland that's circled in the blue. And then doing surgery, we remove it. And these days we do surgery mainly using the robotic system. So then there's a gap here, and then the surgeon will try to connect the bladder and the urethra together with sutures. And this is your new anatomy after surgery. Because the prostate is removed, we lose some of the urinary control. We lose some of the ejaculatory functions. So most men lose ejaculation. And we also can have damages to our erections related to nerve and vascular potential compromise. So before surgery, a man have 2 muscles that control our urination. One is called an internal sphincter, which is the bladder neck. The other one is the external sphincter muscle. After surgery, A is gone, so you only have B. Therefore, we lose half of our urinary control. So when we tell you guys to start doing your Kegel exercises and trying to strengthen the muscle, we're talking about strengthening this pelvic floor muscle or the external sphincter here. So that's the muscle that you're working out. It's not something you can see on the outside, but this is something that you can see only on this diagram. But that's the muscle that we want you to strengthen after surgery to help you gain your urinary control after surgery. Sometimes we might order fancy tests called urodynamics. Urodynamic is a fancy word for a pressure study of the bladder and the plumbing system, okay? In people with pre-existing problems before the cancer diagnosis, such as stroke, such as other urinary leakage problem before surgery, they can have other problems with their bladder. And this pressure-based study can help us identify issues relating to the bladder. So therefore, we can treat, the urination problems beyond just the side effect from the surgery or radiation. So what are the treatment options available? We talk about surgery and non-surgical treatments, and most of the non-surgical treatments are offered within the first year after surgery because your body is still healing. So we don't want to do anything too aggressive in the beginning. And these are the ways that we help you get your life back to normal. Okay, most people wear a pad or diaper. Sometimes people use an external penile clamp, and sometimes people are on catheters. The pelvic floor muscle exercises, something we call them Kegel exercises, are stuff that we all recommend guys do. As I showed previously in the diagram, that that's the only mechanism to control your urination after surgery. So it's very important to get that muscle as strong as possible. Some people will try to limit fluids, on certain activities, so that way the bladder doesn't get too full. Lastly, there's medications that we do to slow down the bladder to hopefully reduce some of that urge, that gotta go feeling. And these days, we use all of them. Is really kind of based on what works best for the individual. Most people, usually start with some kind of a diaper, but then they hopefully with robotic surgery, they get their urinary control back faster, that they can transition to pads. In people that have difficulties with pelvic floor exercises, we even have resources to send them to pelvic floor physical therapists. I tell the guys, for some reason, all the women know how to do Kegel exercise. You tell them to do it, they know how to do it. It's almost like they're born to know how to do it. But when I tell guys to do Kegel exercises, they start doing abdominal crunches, almost like they're doing sit-up, or they're squeezing their butt. For some reason, guys, we're not wired that way. So one of the best feedback on knowing if you're doing Kegel exercises properly is that I tell them just go to the bathroom. When they pee, try to stop the urination midstream. And then they relax and then let the urine comes out again. That's a very easy visual feedback. Are you squeezing the muscle correctly or not? Once you know what that sensation, what that feels like, then you can do it even when you're not in a bathroom. You can do it while you're driving. You can do it while you watch TV. I usually tell the guys, when you watch your shows in the evening, during commercial, you can do some Kegel exercises, and then when the show comes on, you can relax. These days, we don't watch commercials anymore, so you kind of have to figure out another habit to do these exercises. But it's very crucial to do that in the first 3 to 6 months, because that's when most of the healing for your urination occurs. So that's definitely one of the strategies that we have. In people with persistent leakage, after about a year, that's when we start talking about what else can we do, because that's when most of the healing's already done. Most men are unlikely to get better. And we also know that as we get older, our body can leak as well, naturally. So some people might say, I am dry after surgery, and now 5 years later, I'm cancer-free, but I'm leaking again. So that could just be the muscles, and your body gets a little bit tired, a little bit weaker. But in people with more severe leakage, we sometimes offer surgical treatment, and they ranges in bulking agents. Basically, we can inject some material into the urethra to provide a little bit more resistance, a little bit more pressure at the muscle level. So hopefully, it's easier to control. In peace, we even do urethral slings procedure to try to provide more support and help men with minor leakage problems. And then in men with more severe form of leakage, we even do artificial urinary sphincter. It's the fancy water balloon way of trying to help guys regain their continence back. So how do you choose if you want to go this far to have surgery? And these are the stuff that I talk about with my patients. Number one, severity of incontinence. How bad is it? Are you one diaper a day? Are you one pad a day? How full are your diapers? Some people say that I wear 5 pads a day, but they change it frequently because they got a 1 to tiny little drop and they don't like it. They don't like the smell. They don't like feeling wet. So they change their pads all the time. But some people wear, say, only 1 pad, but that pad's soaked. So these are stuff that's important to know. Patient's history, in people that have prior radiation or other kind of surgeries, they might be better suited for one type of surgery versus the other. And last thing, really expectations and capabilities. If you say you want to be as dry as possible versus somebody that just want to reduce the leakage, that's kind of different people, and some people, if you want to go with the most effective treatment method, the artificial urinary sphincter, you need to be able to operate a pump. As you can see in this picture, there's a control pump that operates this water balloon or the sphincter. And if you have dexterity issues, you might have weakness in your hands from arthritis or history of stroke where your hand is not as strong as it used to be. This is not going to be a good option for you because you will not be able to use it. So these are some of the discussions that all urologists, not just me, should have with our patients about how to choose the right treatment. So there's actually a study looking at who are the best people for the sling, because the sling is most popular. And the main reason is that it's easy. Once we're done, we're done. There's no pump. There's nothing that you got to operate. So a lot of patients really want to have the sling, it's faster recovery, but it's not really right for everybody. So this group of researchers try to look at who are the good people who actually do well after this treatment, even though people like it. So they kind of define what the right type of patients are. You should wear less than 4 pads a day. They actually weight the pad and see how heavy they get. You got to be able to kind of contract the muscles doing Kegel exercises and that kind of stuff. You cannot have prior surgery or like cryosurgery, which is the freezing of the prostate, or any radiation. No prior incontinence surgeries, and then you don't retain too much urine after you pee. So these are kind of what we consider ideal patients. So compared to people that don't meet these criteria, you can see the outcomes are very different. In the right group of people, half the people are dry and 92% are very satisfied. But if you don't meet the right criteria, when we just put the sling in you, only 22% of patients are dry. And then only 30% are happy after surgery. So that's why, when you are thinking about undergoing surgery to help you with the urine leakage problem, it's very important to have these kind of discussions with the doctor, and then we will help you using some of these studies and our understanding of who are the right people for each surgery, and we will hopefully match the right surgery with the individual's condition. All right, so I'm going to pause right here before we move on to the next part, and I welcome any questions that you might have about urinary incontinence.
Yeah, thanks for that half of the presentation. Guys out there, any questions?
Hey, Doc, thanks for being here today. Thank you. Appreciate it.
Sure.
Hey, I have a question about the Kegels. I'm not leaking, but I'm wondering if I should just do them as a precautionary measure. And I know that you said we should do them while we're watching TV, but I mean, what should I whip out 20 of those things or? Yeah,
so we now actually start teaching guys to do Kegel exercises before surgery. There is a fatigue issue, so you can kind of overdo it. So some people would say, it's like I'm gonna do it day and night, and then but when your muscle gets too tired, it actually can open up, like involuntarily. So I tell the guys to put in, probably at least 10 or 15 minutes per day. That's why I kind of do the commercials during your evening show, that kind of stuff. So even when you're not leaking, because as I mentioned before, as we get older, all our muscles move slower and it gets weaker, including the sphincter muscle on the inside. So even if you don't leak, if you can remember just to do it, during your commune, during your daily activity, I think that would help.
Okay, great answer, Doc. Thanks.
Mm-hmm.
Yeah, I have another question. I saw on one of your first slides that you said that surgery is a better option than radiation when it comes to maintaining sexual function. I got that right, correct?
Yes.
Yeah, I guess I had always thought the opposite. Now, actually, is it the opposite for incontinence, that surgery is worse for the incontinence side of things?
Yes, so we'll go to sexual function in the second half. Okay. So in terms of incontinence, surgery does have higher rate of incontinence than radiation, because as I showed before in the diagram, we're removing the prostate, we're reconnecting, we're rerouting the plumbing, from the urethra directly to the bladder. So there's you definitely lose that continence mechanism. What happens in radiation is that, same as both for urinary function and sexual function, is that with surgery, you pay upfront. Okay, it knocks you down from 100% to 0, or maybe 10%, and you work yourself back up. Radiation is a more gradual process. So in the beginning, you might feel tired when you do radiation. You say, but it's not, you don't feel anything. You go there, you lay down, they zap your prostate, you walk in, you walk out, right? So most people tell me in the beginning is that I just feel tired, But what happened with radiation is that you start having a decline over time. Okay, so you pay for it later. You don't pay for it in the beginning. Okay, so most people will say, I feel pretty good in the first couple of months, but then at 1 year, at 2 years, at 5 years, the radiation is still affecting the internal organs. So in terms of urination, the radiation guys generally have more urge, the frequency, the urgency. They can have what we call something called radiation cystitis, meaning that when we zap the prostate with radiation, we don't just focus on just the prostate alone. We would draw a circle around it because we don't want to miss anything. And the thing sits next to the prostate is the bladder. So there's some collateral damage to the bladder and the rectum. And so sometimes people can have radiation proctitis. They might have bloody diarrhea, changes their bowel habits, or they have many loose bowel movements. With urination, what they have is the frequency, the urge, and sometimes blood in the urine. So that's what we see more in terms of urinary function. So they're different, so they have different kind of side effects. But unfortunately, that's all kind of a collateral damage from the treatment.
Gotcha.
And I think in terms of sexual function between radiation and surgery, I think it's a little bit different because I'll go over a little bit later, is that most of the surgery are done by urologists. And we are big on a rehabilitation protocol. So we're rehabbing the guys pretty early. Radiation guys, generally, they do more of a wait and see approach. They do radiation, they then kind of do their thing for about a year or two, and then we try to help them at that time. So sometimes one of the reasons why they don't have as good of sexual function outcome in the long term is that they might not have undergone the same rehab protocol as the men would have. So these are all kind of factors that could play into things. But we'll go over sexual function next. That's a great segue into our next part. Any other questions about urinary control or urinary function before I move on?
Thank you.
All right, perfect. So next we'll talk about sexual function. That's actually what I do the most. I direct our men's health center. So I take care of guys, even without prostate cancer, with the same problem. These are some of the things that people complain to me about. They can have ED, which we'll spend a lot of time talking about today. They don't know that they don't ejaculate anymore. Sometimes for the guys is pretty wild. Some people can have actually orgasmic dysfunction, meaning that they have a hard time with climax. They can have sex, I get erection back, but they just cannot climax. And then some people can have what we call climaturia, where they leak urine during sex or during sexual activity. They don't leak all the time, except when they're trying to have sex. Some people can have a Peyronie disease, a fancy word for people with penile deformity. They can have a bend, a curve, changes in their shape, changes in their size, their length of their erections. And lastly, there's also changes in their sex drive, and there could be a psychological impact after prostate cancer treatment that might not want to be as sexually active, or they can lose some of the desire and relationship difficulties. So we'll talk a little bit about ED. So even in guys that don't have prostate cancer, this is a very common problem. Okay, about 50% of the guys, by the time you're age 50, will have some kind of difficulty in the bedroom. Okay. But the good news is that even though it's part of aging, we have a lot of good treatment options for it. So, so I always tell the guys, in addition to surgery, we're also trying to help you, because most men your age needs help anyways. Oftentimes, there are other diseases associated with erectile dysfunction. We know that, these days, as we get older, the only thing that keeps growing is our waist size. And, so it's now common for guys to have a little bit of high blood pressure, a little bit of diabetes, a little bit of high cholesterol. All these things can already slowly build up to causing some circulatory problems related to erectile dysfunction. So if you add those other issues, side effect medication to treat those issues with prostate cancer surgery or radiation, you can see that you have the cards are stacked against you to have a normal sexual function after treatment. So unfortunately, ED, despite all the commercials we see on TV, the couple sitting in different bathtub, which I don't understand, how that make you want to have sex, is still a kind of a taboo topic. Most of the people don't want to talk about it because they're embarrassed, and that some people just don't think there's anything that we can help you, so they just don't want to talk about it. But we do know that it's a very common problem. And that most of the guys usually go to their primary care physician to get the discussion started. And then, but out of the people that want to have a discussion, only 22% of them actually have the courage to seek out help. So that's something that hopefully with the prostate cancer group, and you guys do a great job at informing the survivors and the newly diagnosed guys about being very proactive about seeking help. So so I suspect the rate in your group is probably higher in terms of people who's willing to discuss it and bring some information to their cancer doctors or their primary care doctors. So why do we care about sexual function? We know that it's not just about being able to have sex. Guys generally have problems in the bedroom, feel depressed. They definitely have less self-confidence, and they feel like they lost their manhood. They can have some anxieties build up. They might have difficulties, with existing relationship or forming new relationships. They could feel angry, because it's when you ask, how do you feel today? How's your health? When in people that have trouble with their sexual health, they generally score lower in quality of life. But we also know that in people with erectile dysfunction, they could have other undiagnosed problems such as diabetes or cardiovascular disease. That's why it's important to not ignore any sexual health problems. So these are all the available treatment options. And I'll briefly go through each of them. The oral medication, these are the pills, these are the Viagra, the Cialis, the Levitra, the generic, the branded. The question I get a lot is, are the generic the same as the branded drugs? The answer is yes. So for the guys that, now we have generic options available, it really helped with cost, so most of the time in my practice, we give them prescriptions. We tell them it's okay to use generics. We give them good RX coupons or various other online resources. So they cost is really not a barrier for most men anymore in obtaining therapy. Unfortunately, it might not be effective in people with a history of prostate cancer treatment, okay? Because we know that the pills in general works for middle-aged guys, but if you add the age and other comorbidity factors on top of the cancer treatment, your body might need more help. And more help might means that we have to deliver medicine into the penis directly. Because when you and I take a pill, it goes around the whole body. So you gotta wait. It takes about an hour before it finds your penis. By the time it gets there, only about a small amount of active ingredient actually gets there. If it's enough, it's enough. If it's not good enough, the injections therapy basically is a form for us to deliver 100% of medications into the penis. And that it works pretty well, actually. But for that to work, you got to be, mentally and physically prepared for that. some people might have needle phobia. They say when I get a flu shot, I faint. A sight of blood, I faint. And obviously, those guys injections aren't so good. But injection is more potent than oral medications, and we use it routinely, especially during the early phase of recovery, to get more blood flow into the penis so they can restart their sexual activity sooner. Okay. Vacuum pumps. Vacuum pumps is great for some people, but it's not great for some other people. Okay. Back when I was young and fresh out of training, I make guys do everything. Pills, injections, vacuums, it's a whole regimen and routine. We now realize that's probably not for everybody. So we kind of individualize it. If you're a guy who's recovering from surgery, you don't have a partner, you might be, single or not in a relationship, you don't have a stable partner. I'm not going to ask you to do injections, because why are you doing injections when you have nobody to use that erection with? So for the guys who aren't sexually frequent, vacuum erection pump actually works. It's something that you can do on your own in the privacy of your own home. It allows stretching. It does bring blood flow to the penis. It's not as good as injection because the vacuum pump bring in venous flow. So those blood from the veins aren't oxygenated. Versus injection or the pills bring in arterial blood flow where the blood is oxygenated, so it's better for healing. But it's still doing the job of stretching, still doing the job of recruiting blood flow, so keep the tissues healthy. So that's a very great way to help guys engage in their rehabilitation process. But if you want to be sexually active, people hate the vacuum pump because, as you can see in the picture here, there's a rubber band that you got to place at the base of the penis after the erection's been generated. And what it does is that it's there to pinch off the blood flow so blood doesn't leak out. Okay, because without the negative pressure from the pump, blood's going to go away and your erection will go away. So this rubber band had to be pretty tight, you can imagine. So most people say, well, it's kind of like putting a rubber band around your finger, pretty tight at the base. After a while, you start feeling numb. So you can lose some sensation. So people don't want to have sex with a numb penis. So that's why I don't recommend vacuum pump as a way of helping men become sexually active, but I do use it a lot as a rehabilitation, a stretching protocol. The urethral suppository, this is something called Muse, M-U-S-E. Basically, we can put medicine into the urethra. I don't use it as much anymore these days because for it to work, you got to put pretty high doses. Usually it's about 500 or 1,000 units for that to work, and it burns the urethra. So most people will say, hey doc, I got an erection, but my urethra is on fire. So most men, especially people with prostatectomy, they still have PTSD from the catheter. So they're like, it feels like I'm trying to have sex with a catheter in me. So that's obviously not very pleasant. So for the guys that cannot do injections, we now use a urethral gel instead of a suppository, and that's a little bit better tolerated. Unfortunately, it's not as potent as the injections, but for some guys, that it might be good enough. Okay. So lastly, once the healing is all done, if a man still cannot get an adequate erection, then we usually offer surgery, and the surgeries I do routinely is a penile implant surgery. And that's the one with the pump where there's water balloons that's empty when you don't want to have sex. And when you do want to have sex, there's a pump that pumps the fluids in there. And it's actually, and so for a lot of men, that's what they have to go through to get their sex life back. So in a study looking at men who have tried everything, they actually are most happy with the implant, So with the implant, it works 100% of the time because I'm replacing your body's own mechanism with the water balloon. So they're mostly satisfied because it works as compared to the pills, the sildenafil, which is Viagra, or the injections. But take this with a grain of salt. This doesn't mean every guy needs an implant, okay? This just means that in people who have tried everything and most likely they have failed other treatments, implant actually bring them back and they're able to resume their get their sex life back. So specifically related to post-prostatectomy treatment. So what happened? It wasn't, well, what happened? My doctor didn't tell me anything, and now I have this problem, and if I knew this, I would never have choose this. So So I think, unfortunately, when guys are faced with a new diagnosis, it's very overwhelming. We are throwing a million information at you about cancer control, about the Gleason grade, about the biology, the natural history, genetic testing. There's so much information. It's almost information overload. So they don't always have time, or even if they discussed it, it's hard to kind of retain those things. So just to review, during either surgery or radiation, there can be injury to the nerves, the cavernous nerves specifically, or the blood supply to the penis. Okay, and that's the main mechanism of why erection is not great afterwards. And during the first year after surgery, there's hypoxia or decreased oxygen to the penis because the blood flow is not good. So usually what happens is that the smooth muscle inside the penis can die, and then there can have collagen depositioning that we start depositing scar tissue. So about a year after surgery, there can be permanent changes called corporal fibrosis. Basically, there's scarring inside the penis in a normal, healthy erectile tissue. Now it's been replaced. That's why about 70% of the guys will need help after surgery. So what I do a lot in my day-to-day job is to help cancer survivors, whether it's short-term, long-term, before surgery, before radiation, we start talking about these things. So the goal of the rehabilitation, I kind of describe to them, is that we want to try to get their erection back, so that way they can get their sex life back. We want to try to improve their ability to respond to the different treatments that I discussed previously. And we want to prevent any scar tissues and kind of irreversible changes. I kind of describe rehab like it's like a athlete, like a football player who had surgery. They're not sitting around the sidelines watching the game for a year. They're working with trainers. They're doing all kinds of therapy. So hopefully they can come back, as close to their pre-fighting shape as possible. And this is not that different. Okay, so I also try to set expectations for the guys. Is that if you are a Viagra guy before surgery, the best I can get you is that you'll be a Viagra guy, at 1 year after surgery or radiation. Okay, I cannot make your erection better than you were before. If the treatment make your erections better, guys will be lining up on the streets trying to get their prostate removed or radiation. Okay, so we kind of want to set that expectation as well. And then I see them, during the rehab, we put specific milestones that we want to make sure that, at this point of healing, I expect you to be X, Y, and Z. If you're not there, we will, kick it up a notch, go up on the potency of medications, or do what we have to do to hopefully get you back. And then you can hit those milestones as we expect you to. Unfortunately, there's really no single protocol. They're like, what's your secret sauce? There's no really one single protocol that is going to bring you back 100% of the time. But we do know that undergoing rehab is better than guys that don't. And I think this is as Adam mentioned earlier about why does radiation guys don't do as well. I think that has to do with this. Because most urologists are very familiar with the rehabilitation protocol, but the radiation oncologists are not. Okay, so we actually have worked really hard in trying to get a rehabilitation protocol to our radiation patients, and then try to make sure that we're seeing the radiation patients as well. So hopefully they can get a good outcome in the end of it as well. It's really about personalized treatment. Every man's different. A 60-year-old guy with a 60-year-old wife is different than a 60-year-old guy with a 30-year-old wife. We all have different goals. We all personalize it, and some people might say, I'm only willing to go as far as the pills, doc. There's no way I can put a needle in my penis and I don't want surgery, which is fine. We do the best we can with the pills. We might throw in the vacuum pump to try to get things going. And that's as far as the guy wants to go. You say, my wife and I, that part of our life is not important anymore. So I just want to keep my body healthy. And that's very fair, a very reasonable goal. Some people might say, listen, this is my 5th wife. I got to keep up with her. Otherwise she's going to leave me. And that person might want to go all the way if they need to have an implant surgery to bring their sex life back, keep their marriage, then we go there, you know. So I don't push surgeries on people. I don't push pills on people. We try to understand each person's unique individual situation. I always encourage partner to come to the doctor's appointments. And when I see the patient and their partner there, we know they're going to do well because we got two people there that's motivated. And at the minimum, I know that, you know, whatever I say to the guy gets sent home because the partner's there, instead of you guys playing telephone and only half the message gets delivered. So I'm going to pause right here. I know I did not have time to cover the other sexual side effects, but I'm happy to answer those questions beyond just the erectile dysfunction for the cancer survivors.
Great. Would you mind stop sharing your screen, and then we'll be able to have full page videos of everybody as we're asking questions. Thanks. Yeah, that was a great presentation. Thanks for everything there. A lot of good info. One first question to kick it off. I'm kind of curious, are there any specific differences on the rehab protocol, whether you're a surgery patient versus a radiation?
Yeah, I think that's a great question. And we actually don't have too much differences. So for most of the guys in the beginning, I usually start them off with a low dose Cialis every day. Okay, so that's the 5 milligrams of Cialis. Most guys are saying nothing happened. I'm like, I know, ain't nothing gonna happen. Okay, we like to use Cialis over other type of PDE5 inhibitor because the half-life is longer. Okay, so whether it's generic or branded names, generic pills are called tadalafil, because we want to get the baseline blood flow going. So I believe for the rehabilitation purposes, we want to get blood flow going 24 hours a day, not just for the 4 to 6 hours. And then we might add something on top of it. We might add a full dose Viagra, more Cialis, or Levitra. We're using combinations in the beginning, okay, to see if we can get enough blood flow going. If it's not enough, that's when we start talking about, injections and something a little bit more invasive. But at the baseline, whether you have surgery or radiation, we want you to have at least a baseline blood flow going using the daily low dose Cialis. And one of the questions I get a lot these days, I didn't have a chance to add to my talk, was about shockwave therapy. I think you got to live under a rock to have not seen an advertisement for shockwave these days. And while it make a lot of promises about how we can make you 18 again, we're going to cure you of your ED. All the treatments that you've been getting are just putting a Band-Aid on a problem. You're treating the symptom. You're not curing my ED. I think the juries are still out about these type of regenerative treatment. So we learn a lot about shockwave, stem cells, PRP from really our sports orthopedic colleagues. People have injury, they're undergoing rehab, they add these kind of adjuvant things to help your body heal. So it makes sense, right? We're talking about rehab. If the athletes are getting PRP, stem cells, shockwave treated on their joints, on their hip, on their back, on their knee, on their shoulder, their elbow, why shouldn't we do that on your penis? Unfortunately, out of all the existing research, it hasn't panned out. So while I still believe undergoing rehab better than none, I believe there are other more cost-effective options than shockwave for the rehab protocol at this time. But we're doing research at UCSD. We're doing research trying to identify the right group of people that might benefit from incorporating shockwave in their rehabilitation protocol. But right now, we're still in a very preliminary phase of trying to understand that treatment modality.
Gotcha. I want to go to Bob to see if he has any questions, because I know that Bob had to sign off in just a few minutes here.
I do. Thanks for getting to me. I'm kind of stressed and sweating here, Doc. I had 28 treatments of proton therapy just about 3 years ago. The 19th will be 3 years from Dr. Rossi. And I was fine performance-wise before I had the treatment, and I'm fine now. My question is do I have something to look forward to in the future?
No, I think you're doing great. If you've gone a couple of years out and you're just doing okay, I think about 3 years, probably your new normal.
Oh,
Okay. So I think you obviously had a great result, which is awesome. But unfortunately, as we get older, your body can need more help. Okay.
Sure.
So
Mhm.
I think any future decline is probably less related to radiation at this point.
Okay.
It's probably
Got
just
it.
related to your overall health. So the things my advice would be to stay healthy. You know, you look like you're pretty fit, look like you might be a golfer, you know, you're wearing your
I try.
you know, so and so stay active. You know, that's
Okay.
that's what you can do to not just for your sexual health, but your overall health too. You know,
Right.
but I think you're out of the woods.
Uh,
You had 3 good years. Dr. Rossi did a good job on you. You know,
I see Dr. Bagrodia now over at your place. He's my urologist. So
yeah,
thank you.
yeah, no
And hey,
problem.
one last question. Can you write me a prescription for more sex with my girlfriend?
Yeah, people always ask for that. Unfortunately, that's on your own, you know. But the good news is that we actually know there's a prevalence of sexual health problems for the partner, not just for the patient themselves. You know, because I think, as you know, your cancer diagnosis affects you and your loved ones. You know, so we're all going through this together. So we actually have resources now at UCSD to help the partners as well. So if you want names of people that that they help out with the partners, we're happy to help. You know, because obviously, as you know, women going through changes as well as they get older.
Right.
Yeah. So but I have a feeling that you're doing so great. You know, you just gotta buy her more flowers, and you'll be just fine.
And
Thank you.
I'm glad you brought up the point about partners, because when we had an in-person meeting a couple years back now, it was actually the wife of one of the members that came to me asking the most questions about sexual side effects and given her husband's future treatment and so forth, and wanted to know, what about all of these things, do they work and so forth. So yeah, the partners are excellent.
Yeah, I think it's, as I mentioned before, most guys are very embarrassed when it comes to sexual health issues, so it takes a lot of courage for guys to even bring it up, so sometimes we need the girlfriend, the wives, the partner to kick us in the butt to get us to doctors and to be right up front and center, because they can tell we're suffering, and then they want us to be happy and they want to bring us back too. So that's why I mentioned earlier, I love it when I open the door in the exam room, there's more than one person sitting there. When there's more than one person, I know this is going to be a home run. And then when they're alone, it's sometimes they're alone because their partner can't be there. They're busy. But we're definitely a very partner friendly. They're welcome to all the doctor's appointments.
Bob, did you have other questions before you had to go? You're on mute again.
I don't. I was just typing you a note saying that I'm getting ready to take off. So thank you to all of you. I appreciate it.
Thank you for coming.
Thanks for helping.
Thank you.
Yeah. Dr. Hsieh, I'm familiar with Viagra and Cialis, but Levitra is new to me. Can you tell me a little bit about the difference of Levitra compared to the others?
Sure. So, we have a lot of drugs available these days. People always ask me, which one's the best one? They're always like, hey, doc, what's the best one? And to me, they all do the same thing. What's different is really how fast they kick in, how long do they last, and different side effect profiles. So traditionally, Viagra is considered the most potent. So people think that's the strongest one. But unfortunately, that's also the most side effect. People can have, issues related to, facial flushing, vision changes at night, and stuffy nose, that kind of stuff. Cialis, and then is something you can take, with less of a dietary restriction, as compared to Viagra. You don't have to watch as much as what you eat and drink, and it also lasts longer. The Levitra is thought to work faster. Okay, so waiting an hour, you can kick in about 30 minutes after taking it, So, but they all kind of do the same thing. So I kind of tell the guys, you kind of have to try a couple of them. I give them maybe a handful of pills at a time in a prescription, and then they try them and they kind of figure out a combination that agree with their body the best, both in terms of efficacy and also side effect profile. But we luckily before. It's a big ask for guys to undergoing rehab because these pills are so expensive. I remember the days where a month of Cialis was like $500. Today we can get them for under $20, for a month's supply. So that barrier for rehabilitation is really significantly reduced with the pricing.
Yeah, that's definitely been a fantastic difference from when I was nearly about to pay $2,000 for my first month of Cialis versus I pay $50 now.
Yeah.
But let's see. Yeah, I'm just curious. Is there, I have a feeling that this might entirely be in my head, but I have kind of noticed that when I skip my Cialis pill for a couple of days, actually my incontinence gets a little bit worse. Is there any science behind that, or am I just overthinking it?
No, you're right. If you pay attention to some of the commercials, the low dose Cialis actually is also approved for guys with urinary problems. Okay. So we actually don't know how it really works, because obviously the drug was intended to help men with erections. But people take them, say, you know what, I pee a lot better, so I like that side effect. So what we think it does is that it acts on the bladder neck level specifically. So if you have a little bit more of a frequency, the urge that gotta go feeling, the low dose Cialis actually take care of that problem pretty well. So it's not only in your head, so it does help with urination. So I think that's probably one of the reasons why we know guys also need help with urination as well, after prostate cancer treatment. So that has been probably our, everybody take it almost like vitamin, so that way kind of get the blood flow going. It might help you a little bit with urination. That's icing on the cake, but it's not only in your head.
Gotcha. And one last question for me before I turn it over to, I'm sure, Bill, who's chomping at the bit. So well, I had one urologist who had me start taking Cymbalta. I guess originally Cymbalta had been researched for its benefits to urinary incontinence issues. Had not been conclusively, I guess, proven yet. It then became a antidepressant or anti-anxiety. I forget which it actually was. On the downside, not only did I have severely bad side effects when I came off of that, but I actually think that it was stopping me from being able to have an erection. So my question is, given the side effects of ADT and the loss of the testosterone, are there any updates to addressing the side effects involved with that? So, for example, I went on to bupropion and Celexa originally just because I was so depressed when I started ADT. But obviously, that also suppressed the sexual side effects. What's kind of the latest suggestion on that side of things?
Yeah, so unfortunately, there's a lot of side effect to hormone deprivation or ADT, and then depression is one of the big ones, and then we know there's a baseline depression in guys that survive prostate cancer in the first year after treatment. Guys just like, oh my God, I have cancer, so you feel depressed, you throw hormones on top of it, doesn't help, antidepressants, like you mentioned, is a different beast in itself. It's when you're messing with the chemicals in your brain, everybody kind of responds differently. That's why it's a kind of a trial and error on what doesn't agree with other guys. I don't really have a go-to medication that is pretty well tolerated versus not. We do try to avoid antidepressants if we can, and we try to employ more of a psychotherapy mechanism to try to really avoid medications or dial down the medicine as low as possible, because it's usually dose dependent. The more you take, the more side effects you have. So unfortunately, that's one of the challenges we have, is that we don't have a lot of mental health professionals available in general, and also for the prostate cancer survivors. So we try to use all the resources possible to avoid medication if we can.
And I know that I believe Effexor is typically very helpful with dealing with the hot flashes, but again, that has pretty severe sexual side effects. Mm-hmm. Is there anything more advanced than Effexor for that type of thing?
Yeah, I think the bupropion or the wellbutrin is generally accepted as the one with the least sexual side effect. So we try to put people, usually start them off on wellbutrin first, and then if it's enough, hopefully, and then really, the good news is that most of the ADT side effects are reversible. So when you get your hormone back, you feel better, So it's a short-term thing. Very few people need to be on it for the long run, because because these days we don't put people on AADT forever anymore. So it is a 6 month to 2 year of kind of a downed situation, but hopefully we can get you back once you take you off these medications.
Excellent. All right, let me turn it over to Bill, who I'm sure has some questions.
Thank you. My first question is not for me because I haven't had surgery, but one of our members mentioned that he lost 2.5 inches after surgery. What would you say is the normal range?
Yeah, so it's everybody's different, but everybody's the same in the sense that nobody is so well endowed that they have 2 inches or 2 centimeters too loose. Okay, I never met a man that say, I was pretty big, so I'm happy I lost a couple inches. Okay. Most of the time people lose size is because during the healing process, they did not rehabilitate as much as we hope that they would have, because the scar tissue buildup, the smooth muscle, dying from the lack of oxygen is the reason. There's really no accepted normal amount of length lost, to be honest with you, because that's not supposed to any man, we at the same time, I do have seen men with success by introducing a stretching device, such as a vacuum pump in that setting to try to get some of that size back. Okay, they might not get all their size back, but by using a stretching protocol, I usually tell guys to do 5 reps of 2 minutes per day, meaning that you put the vacuum on, generate an erection, and keep it erect for 2 minutes, fully erect, and then you take the pump off, and you repeat that. So you do 5 reps of 2 minutes. So it's about 10 minutes per day. By doing that at least 5 days a week, they should have a visible difference in their size from before we start the stretching protocol. Unfortunately, they will never be 18 again. So something we're always measuring ourselves against our old self, So it's not too late to do stretching.
Okay. Next question is regarding hot flashes. It seemed like last time you spoke to us, you talked about a drug called Megace, and one of our members said people are getting help from Neurontin, and then Aaron just mentioned Effexor. Can you comment on whether those are good, whether there's one that's best?
Yeah, so they're all for different kind of reasons. Megace is a hormonal pill. Okay, so the hot flashes is usually a hormonal reason, right? Because when you go undergoing hormone deprivation, it's like women going through menopause. They get hot flashes too. So Megace is a hormonal treatment to try to offset some of that hot flashes side effect. The Effexor that Aaron talked about is
even
really
when you're on ADT.
Yes. Yeah,
Okay,
that is only used during ADT. We don't give it to guys, when they're not in ADT. The Effexor is mainly to manage more of a depression side effect than hot flashes side effect. Okay. So kind of depending, because ADT have a bunch of other like bad, horrible side effects too. So that's why we don't use it long term. Back in the day, we used to put people on hormone deprivation for like
years,
forever, and then people were dying from other complications, not cancer, but from complications of ADT. So, and then the Neurontin is mainly used for neuropathic pain, so if you happen to also have some discomfort down that region from radiation or from surgery, then the Neurontin can help. It's almost like help people with nerve problems. Some people use it for muscle spasms, some people nerve, just mainly for pain issues. So we kind of use these things. These are all kind of temporary fixes to help them, manage the side effects. But unfortunately, once we get their hormone back, then a lot of times people don't need this help anymore.
Okay, and then I think maybe my last question is the last time you talked a little bit about bipolar androgen therapy, and I'm wondering what your current attitude is about it. You mentioned cycling on a 3 or 4 month schedule, and it seemed like the original people were doing it monthly. And so I'm interested in an update here in 2022.
Yeah, it's still kind of a research interest at this point. You know, we don't really have a one good protocol. So what happened is that these are usually for men who initially responds to ADT. You're when we put you on the hormone shots, you were to lower your testosterone, your PSA is nice and low. Okay. But after a while, your PSA start creeping up, meaning that you develop hormone resistance to ADT. Then we want to shock the cancer with high dose testosterone. So you go really high, really low, really high, really low to bring the PSA down. Okay. So unfortunately, there's still no acceptable protocol that can bring the guys back to hormone. So that's why these days, if you become hormone resistant, we start using other things such as chemotherapy agents and other newer immunotherapy type of treatment to treat the cancer, because that shocking high and low only work for a little bit, and then we don't have a good durable result in those guys. And plus most guys are ready to get off their ADT anyways, so they're like, oh, it doesn't work, great, give me my testosterone back, give me something else, so we don't try to torture you guys much longer, so we do move on to other kind of chemotherapy agents and things like that.
And what testosterone level did you shoot for if you helped a man with BAT?
So
on the high side.
it can be over 1,000.
Okay, because my oncologist wanted me over 1,800.
Yeah, so it's exactly, it has to be high dose. For normal men, we keep them probably around 8,900 the most. So over 1,000, anything over 1,000 is considered super therapeutic. So but it's really based on what your PSA is doing. If your PSA is behaving, then that's good enough. If the PSA not behaving, they might try to go higher, or they might just change to something else.
Thank you. Anybody else?
Just to, I know that we've run over a little bit, so hopefully you got time for one more question. 3 years ago, you'd mentioned about how testosterone levels in one man can be different than in another. One guy could have a lower testosterone, but feel the effects less of it. And you'd hope that someday you'd be able to basically measure in a blood test, how easily that man can use his testosterone essentially. Do you have any update on that side of things?
Yeah, so we're definitely learning a lot, and one of the things that we learn is really how the mind works related to testosterone. So many of you on ADT, it's not just physically you don't feel right, your mind doesn't feel right. So in addition to depression, we know that people's cognitive function not as good. They told me they have what we call almost like a brain fog, so it's like hard to think, hard to recall, where I left my keys, what are the numbers, all this kind of stuff. So now we're doing more research on, we know that the testosterone actually affects the brain in ways that we cannot see in the MRI level. So we actually are doing studies in men undergoing ADT on measuring their cognitive function. And we have seen that from where you are, we give you ADT, and then when your hormone gets back, there's actually very profound impacts on how your mind work. So we hope obviously in the future, we can use that as a target to help guys, not just for prostate cancer patients, but also for Alzheimer's patients. And there's a lot of people that's losing their, mental, cognition as they get older. And then so we're starting to learn a lot of the how the hormones affect a male brain works. So hopefully next time we talk, we will tell you, this is what you need to be if you want to still remember all your grandkids' names, and what was the first song, what's the name of the song, your first dance at your wedding, all those things, so but because what we realize is that the memory is in there, but you can't access it when your hormone's low. Mm-hmm. But so we need to help you, hopefully using hormones to get your body to be able to access those memory again.
Wasn't that interesting? You learned something? I think you're particularly interested in the more questions on testosterone. We have a gentleman here who is on testosterone. I asked him this morning how he's doing. He's fine. He's great. He's got energy. Things like that. So let me ask you a question. I heard at a prostate cancer meeting the frequency of ED for most men is if you're 50% have ED, if you're 60 to 60%, and so forth, all the way up to 90. Is that accurate?
Yes. So this, like I mentioned before, erection problems is common to all men as we get older. Like you said, 50% of guys at age 50 needs help. 60% at 60, 70%, 70. So even if you did not have cancer treatment or prostate cancer, you will need help anyways, okay? Back in the day, we used to say that's normal part of aging. You know, it's normal for grandpa to just doze off, you know, after dinner and then, you know, just let him be. But in today's world, we're living longer, and most of us want to age well. We don't want to just accept aging as aging. So that's why erection is one of those things that is a disease of aging. If we live long enough, we will need help. So you're right about the prevalence of erectile dysfunction.
I want this group to know that, and if your urologist is over 50, guess what he has? He has ED too.
That's why he won't give you any samples, because he's keeping it for himself.
And that's why they are not necessarily forthcoming and want to discuss it, see. So if you want to talk about it, you know, you have to bring it up to your doctor, and it could be a help to you. So don't be hesitant to ask questions. Let's start over here. Any questions? Yes, sir.
Yeah, can you go back about 3 slides? You said treatment for, right there.
Okay.
Forward one more. Treat anorgasmia.
Mm-hmm. So anorgasmia, as the name implies, is trouble with orgasm. It's not uncommon. So we start thinking about these things as like, sometimes terms are very confusing. People think they can get an erection, that means they can't climax, okay? Some people think that if I can't get an erection, or if I lose my ejaculation, that means I cannot climax, you know? So there are actually very, very different processes. And prostate cancer treatment can affect it differently. So as I mentioned before, erection is talking about blood flow. If you cannot get an erection, it doesn't mean you cannot climax, okay? Unfortunately, after prostate is removed or you have radiation, usually people don't ejaculate anymore, okay? And so they have what we call anejaculation. That doesn't mean you can't get an erection. It doesn't mean you can't climax. It's its own thing. It only means you cannot have kids anymore without help, okay? The last part, climax. People can not have an erection, but still climax normally, okay? Climax is in your brain. Your orgasmic function is having to do with your brain. It has nothing to do with your erection at all. But it's an interesting phenomenon that's not very well understood. Some people tell us that after they have prostate cancer treatment, it takes a long time for them to climax. It's called delayed orgasm, or they cannot climax at all, okay? But you're like, well, you didn't do anything to my brain, at least as far as I can tell. You only did work on my prostate, right? So it's poorly understood. I don't know how much of it is neurological input versus a psychological or a neural changes after cancer treatment or diagnosis. People can get depression and various neurological changes after cancer diagnosis. But how we help men is that it's very difficult to treat. There is a hormone, a neurotransmitter in our brain called prolactin, okay? You might hear about women with prolactin because that's when a woman have a baby. Prolactin is the hormone that induces a woman to make breast milk so they can breastfeed their baby. But prolactin is in men's body too. Prolactin is normally released during refractory period. So after a man climax, there's a period of time we cannot have any sexual activity because our body secrete this hormone called prolactin to tell us to relax, take a break, okay? You need to recharge before you want to go again. And so prolactin is a negatory hormone to our body to tell us to slow down. So we can use medicine to block prolactin secretion in the brain. So you have less prolactin in your body, hopefully will help you improve the ease of achieving orgasm. It works in about a third of the guys, but there is medication available.
Okay, question over here. Yes, sir.
About the ADT and libido.
Okay.
ADT suppress libido,
Yes.
and just so how you overcome that.
Yeah, so most men on ADT is not gonna feel well, okay? Because they're castrating you. So when your testosterone level is 0, which is, or less than 5, whatever the lab value you can measure down to, you're not gonna have any sex drive. You're not gonna get normal erections. You're gonna feel weak, you're gonna get hot flashes, you're going to potentially gain weight, you can get nipple tenderness. Unfortunately, while you are on ADT, we can manage some of the side effects such as hot flashes and give you more help with erection. We cannot bring your libido back until we help you with your testosterone. So there's nothing we can do to help you with libido during ADT because that's a direct relation to your testosterone level. So until you're done with ADT, your body is able to bounce back some, or if we give you testosterone, then that's how we help you. But during ADT, unfortunately, the poor libido is a known side effect.
Can you use that testosterone while you're on ADT?
Usually not, because that kind of defeats the purpose, because during that period when they're doing ADT, they want to starve your cancer cells from testosterone. So once the cancer cells are all dead or they're all under control, then giving testosterone is safer. So usually not.
Let me bring up the subject. It's called dihydrotestosterone. When I came here 12 years ago, I was on Lupron and it devastated me. And then Gene and some others say, what you ought to do is take Avodart and Cassidy. And I did that. My testosterone was over 1,000. My dihydro was 0, and I had a sex life. And my PSA was 0. And then over time, I had to take, Lupron, I took Firmagon. By the way, Firmagon really means firm is gone. But I don't hear anybody talk about dihydrotestosterone anymore.
Yeah, well, it's kind of people are trying to stay away from a lot of the hormonal treatments because as you probably going to have a speaker talk about castrate-resistant prostate cancer, meaning that we now know that hormone can help you with your prostate cancer, but it's not a good long-term treatment in terms of your quality of life and also cancer control. And people have tried various cocktails of, do I block testosterone? Do I block dihydrotestosterone? Do I do intermittent hormone deprivation? Or sometimes they do what we call bipolar, meaning that they lower your testosterone, and then they give you too much testosterone in this up and down fashion to almost shock the system to control cancer. So I think this hormone treatment for cancer control is still evolving. That's why you see so many new drugs. They're usually very, very expensive, but there's a lot of ads on the commercials. So that means we haven't really figured out yet. But we do know that if we keep you on androgen deprivation or ADT long enough, the cancer will also develop resistance too. That's why when you start talking about castrate-resistant prostate cancer, meaning that those now all of a sudden testosterone, starving them of testosterone is not enough anymore. Now they start doing chemotherapy and various other drugs. So some people say maybe I should just take medications like Avodart or Proscar or finasteride to protect me against prostate cancer. And that's been also studied as well, and it hasn't really panned out as a drug to prevent cancer either. So, but it's evolving. So, but that's why we try to balance cancer control and also make sure you still maintain your quality of life.
Okay, any back there? Yes, sir.
How effective is acoustic shockwave therapy for ED?
Okay, that's a very good question. The question is about shockwave treatment for ED. And as many of you know, probably have seen the commercials on the TV or the paper about shockwave. So the idea is that by using ultrasound shockwaves into the penis, you can regenerate it. This is the same concept as stem cells or PRP, plasma-rich proteins. You might have heard about all these treatments. Unfortunately, it's very experimental, and it's not FDA approved, and it's purely done in these for-profit centers currently. And it's been used, however, internationally for a while. And when I go on international meetings, I have heard some mixed results. In general, it can potentially work in guys with mild erectile dysfunction who used to take Viagra or Cialis, and then as they get older, the Viagra and Cialis stops working. So then by undergoing shockwave treatment, all of a sudden the pills can start working again. That's probably the situation where I have heard positive results. Unfortunately, in people with cancer treatment or cancer side effects, your body is battling more than just the normal aging process. You also have the side effect of treatment, the nerve injury, the blood flow issues, so it's probably not gonna work. But with that said, we're still doing research, and then since the Men's Health Center is open, we're starting a study looking at shockwave in men with erectile dysfunction, and it's gonna be a placebo-controlled study, so you might get the shams treatment, but it's gonna be free, okay? So once we get it all set up, then we will advertise it, hopefully to the group. So if anybody's interested in participating, we're happy to get you all involved, but unfortunately, specifically for cancer survivors, that's probably not gonna be the ticket for you to get you back to your pre-treatment shape.
Okay, question here.
Yes, I've heard of a Priapus shot or P shot. Is that on your radar?
Yeah, so that's kind of the P shot or the private shot. Those are kind of falls in line with the stem cells, the PRP. You know, you might hear about athletes getting it injected in their knees, like, or back, you know, and some people swear by it, some people don't swear by it. But unfortunately, for erection problems, it hasn't really panned out. So save your $1,000 and don't waste your money.
Okay, in the back there.
I was wondering about, you said low testosterone also creates different problems. Is that right, like in cardiorespiratory?
Yes, so we know that people on long-term ADT, where they have very low testosterone level, they're at increased risk for cardiovascular events, and they're more likely to get strokes or heart attacks, and they're also weaker, so they have decreased activity level. They're more likely to gain weight. They're more overweight. They can also have bone health complications, where their bone is no different than women after menopause get osteoporosis. So if you fall, or you can break your hip, and so these are some of the complications of having low testosterone for prolonged periods of time.
Is there a counter for that? I mean, I'm going through hot flashes, and now he's going through it, and irritability and insomnia. Have you discovered what can counter that?
There are some medicine we can use to treat hot flashes. They make it called Megace. So there are some medication we can use to treat. But unfortunately, some of these side effects will have to write it out until you're done with the hormonal treatment. Because obviously we cannot, and so that's why we used to give estrogen replacement treatments for women going to menopause, and because we try to do the work that your body cannot do anymore. And in today's world, we still do, but it's a little bit controversial. You want to make sure that your heart is healthy, because they worry about blood clots as well. It makes sure you don't have breast cancer and all that kind of stuff as well for women. But for men, we do. It's true. When you have low T, you don't feel good. It's more than just sexual function. People have decreased energy, irritability, like you say. They have cognitive function declines. Their mind isn't as clear. They call it a brain fog. They can't remember where they left their keys. They can't remember people's names or phone numbers. So there are other whole host of quality of life issues, not just sex. So that's why we try to minimize the duration of any time we keep your body with hormone imbalance.
Okay. Yes, sir.
You use the term long-term ADT. I have serious heart situations, stents, diabetes, and they're recommending 6 months of ADT. Is that a long?
No, 6 months is probably the standard. Everybody, if you were to get radiation, 6 months is standard. That's what the study shows, that if you do radiation alone versus radiation with 6 months of ADT, the cancer control is better when you combine the radiation with ADT. 6 months is not considered long-term. There were people, I'm sure you remember, the prior group members that come here, they were getting Lupron shots for life. You know, they would go to the doctor's office and just get shots every 6 months, every 3 months, and then there was like no end in sight. That's what long-term. But 6 months is not considered long-term, it's standard.
For the heart issues, that's only if it's long-term?
Exactly.
Okay.
Hey, question.
Yeah, does testosterone treatment causes cancer to come back?
It does not, okay? So we now know that, so that's the old school way of believing it, but there people have given testosterone treatment to people with high-risk prostate cancer, Gleason 8, Gleason 9, Gleason 10 disease, and have found that there's no difference in recurrence rate or rate of metastatic disease. But with that said, we still want you to have your cancer treated first. You know, some people might say, well, I don't want to have my cancer treated, I just want my testosterone. I don't think that's right either, okay? But once you get your cancer treated, we're very comfortable, because the thing is that if I give you testosterone, that can kind of, in some ways, can alter your PSA. And that can make the cancer doctor have a hard time monitoring your cancer sometimes too. So once you get your cancer treated, once we know what your PSA is supposed to be and it's at the expected level, then giving you testosterone can monitor you better. Yeah, but so I will withhold testosterone to patients who needs cancer treatment but doesn't want to have it done yet, because I still, even though it doesn't cause cancer to spread or get worse, we don't want to ignore cancer either, you know. So we do recommend people to have cancer treated first if they need it before we give them testosterone. But active surveillance is different. If you're on active surveillance, your cancer is under control and they're dormant, they will not change.
Why do certain doctors still believe that?
Well, the reason is that it's medical legal in some ways, because they don't want to get sued. So that, you know, God forbid, you know, you have a recurrence, and that they don't want to get sued for giving you testosterone to cause the recurrence. You know, people might get sued, so that's one reason. The second thing is that, you know, it's one of those things. You know, there's not every doctor believe in rehabilitation protocol. You know, some people still feel like treating your cancer is the only priority. They might not prioritize your quality of life and your urinary sexual function as much as you and I prioritize that. So I think that's why it's important to discuss just like, you know, we discussed. That's why you're here. You're informed. You want to discuss all your goals with the doctor, and then they might be more open. Maybe the doctor didn't know that those things are important to you. You know, then they're just happy that you're cancer free. You know, so and that's why at UCSD we have cancer doctors that do nothing but cancer all day, and there are people like me take care of cancer survivors, because we have different priorities. And sometimes, you know, our priorities, there's things we do at diagnosis, there are things we do at treatment, and there's things we do at your recovery for your long-term quality of life. So that's why it's a team of us. It's not just me. You know, we have a bunch of people that we all work together.
Let me just comment, you have a fellowship at Baylor.
Mm-hmm.
Baylor is one of the leaders in considering testosterone, is it not?
Well, yeah, we do a lot of research, but now that there's research coming out of Memorial Sloan Kettering, out of Johns Hopkins, you know, I mean, in Texas, we have MD and Anderson, so we have a lot of cancer patients, but this concept is...
Not in Southern California.
It's
different in attitude about that down here versus LA.
Yeah, probably. Yeah.
And people, he's in a more modern world.
Mm-hmm.
Okay. Back there, and then you're next.
Houston.
You, yeah.
You.
With testosterone treatment, does that inhibit the body's own production in any way?
So the question is about, does testosterone treatment inhibit your body's own production? The answer is yes, okay? When I give a man testosterone, or if I receive testosterone, my body get lazy. is stop making my own hormone and stop making my own sperm. Half of my job at UCSD is to help people to get pregnant, because I also do infertility. And a lot of the infertile men have hormone problems too. And I cannot give them testosterone because their body stopped making their own hormones and sperm. So giving a man testosterone is like giving them birth control pill. That's why you hear about jokes about bodybuilders with testicles the size of raisins, because they all shrivel up to nothing. So you're right, when I give you testosterone, your body will most likely stop making your own hormone, okay? That's why these treatments are lifelong, and that's just a known phenomenon.
Okay. Doctor, I am on hormone therapy, and gradually my hot flashes got more and more. And I was talking to some of the guys in the group, and they recommended gabapentin. And my hot flashes are minimal now.
Great.
Because that's something. Pardon me?
Gabapentin.
Gabapentin. Gabapentin.
Yeah. It's either gabapentin or Neurontin, and these are drugs that are used to control neurological pain. So, but there are various medicine you can try to mitigate. But unfortunately, it will not go away until you're done with the ADT.
The second part is. Thank you for that. You have a question? I do. Now, I've heard that if you're on, and it's all an individual thing, if you're on ADT for like close to 3 years, you're not going to come back.
Even 6 months, you might not come back.
Okay, so.
That's not okay.
Pardon me?
That's not okay.
Oh, I know. I'm just saying, okay, that I understand.
Yeah, exactly. So unfortunately, most guys, most people with prostate cancer, you're probably in your 50s and 60s and maybe 70s. Or 80. No, I mean at the time of diagnosis. So most of guys already have about 30% of guys age 50, they already have a decline in their testosterone level. That means that your body is going to stop making testosterone, making less and less and less. So you can imagine that, if you're 18 years old at your prime, I can knock down your hormone, your body can recover better. But when you're already not 100% at age 50, and then I'm going to take away your hormones and ask your body to bounce back, you probably aren't going to bounce back very well, okay? And then that just is no different than you pull your back today versus you pulled your back when you were 16 in high school, So the recovery after ADT is not great, but we do give your body a chance. We give you 6 months to a year to see what you can do, So because if you can do enough work on your own, we don't need to give you medicine that you don't need, But the take-home point is that if you do need help, there's a lot of things we can do, and now it's acceptable for you to receive testosterone if you need it, even if you have prostate cancer.
Okay, question there.
If you're on injections for a long period of time, like I've been on injections for 10 years, is there a cumulative damage from using the trimix mixtures? Because I've noticed that not only the strength, but the dose has to be increased, and I'm 78 now, and it's not working.
Okay.
At large dose.
Good. So the question's about injection treatment for ED, and do you over time what happens? And so it's not uncommon that guys start taking Viagra in their 50s, and then into their 60s they start doing injections, and then in the 70s they talk to me about surgery. And this is not just cancer patients, because as we get older, our body need more help. Okay, so it's not uncommon that you have to go up on the dosages. Maybe when you're in your 50s, you're just starting to take Viagra, you bite off a little bit of the pill, and that's all you need. And then they're 60, you're taking a whole pill, and you still need more help. It's not tolerance, it's just your body's circulation needs more help. So if you were doing injections, there is a lifespan of how long these medicine will probably work for you, okay? This is irrespective of cancer patient. If you happen to have diabetes or other comorbidities, then that will accelerate the process a little bit more, But if you had a 10-year run with the trimix, it's probably time to bump it up to something called quamix, Okay, the medication can become more potent by adding more ingredients to it. So Trimix, as the name implies, has 3 ingredients. And then we have one more medication called Quamix. We add a 4th ingredient to it. That's unfortunately the end of the road for the injections, because we don't have something with 5 or 6 or 7 or 10 ingredients. So, it's not uncommon. People need more help with time goes on. And some people do tell me that they can have scar tissues from injections, and scar tissue can cause deformities. But scar tissue also makes it hurt less. So after a while, people say, it doesn't bother me anymore, it doesn't hurt anymore. So we do have to be careful about scar tissue. Sometimes it can help and it can make it worse.
The scar tissue is detectable, so is there any, what would you call it, undetectable type damaging being done by the injections over?
Not really. We tell the guy usually to alternate side do injections, but most men are dominant in the right hand or left hand, so you probably end up using your dominant hand majority of the time anyways, unless it's causing you problems, we just let you do the way that's convenient for you. If you're still able to achieve the response that with the right dosages, we don't try to interfere with it.
Yes, sir.
I was wondering, what's your opinion about proton
beam?
radiation therapy? They claim that there aren't that many side effects.
Yeah. So proton beam. Questions about proton beam therapy. Proton beam is a form of radiation treatment. Okay. It's a very intense radiation treatment. So the pros of the proton beam is that it's more powerful than standard radiation, and so you need less treatment. You don't go through as many weeks of the radiation treatment. And in terms of cancer control and side effects, there's no difference in cancer control. If you undergo standard radiation treatment or proton beam, the cancer control is no different. Unfortunately, the side effects are usually more severe. Okay, because you can imagine that now we're zapping your prostate with something that's 100 times more powerful than what we used to do. So any collateral damage, whether it's in your erectile function, in your GI, in your bowel movements, or in your bladder, that can be more severe too. So that's one of those things. But there's a lot of marketing for it. Because there's a lot of marketing for it. Just down the street, we have a $1 billion proton beam center. It takes $1 billion to build a proton beam center. So so it has been shown that in certain cancers, such as brain cancer in kids, it's great. Okay, but for prostate cancer, it's really not that different than standard radiation treatment.
Okay, yes, sir.
Would you comment on HIFU then?
Yeah. So HIFU is another form of treatment for the prostate cancer. There is a movement toward what we call ablation of the prostate. Before, when you have cancer, we used to just treat the whole prostate. Now we should talk about focal therapy. You might have heard about that, meaning that if you only have prostate cancer that's detected super early, just one spot in the prostate, why do we have to do the whole thing and give you all the side effects of treating the whole thing? So HIFU cryotherapy has emerged as a treatment for what we consider focal therapy, meaning that if there's a very small spot in your prostate that have problems, let's just zap it for now. With either we can freeze it or we can put HIFU onto it, and then by not treating the whole prostate, you have a lot less erection problems, a lot less urinary problems. So that has kind of become, so that's been used for that treatment effectively. But if you're going to treat the whole prostate with HIFU, it's really no different than treating a whole prostate with radiation or surgery. That's why we use HIFU or cryotherapy, where we freeze the prostate in what we call in a focal therapy treatment.
Okay, I've got a question here. Yes.
I went through the proton treatment and I'm on Lupron now. Did I hear you correctly? If you're on Lupron, you're wasting time trying to do anything with creating erections.
He was on
Service-
Lupron, and he said it's a hard time to create erections after Lupron. Was that your question?
Well, what I'm asking is there any point to going through the,
So is there any point going to rehabilitation protocol? Yeah, so for you, specifically, you have gone the radiation, the proton already, and you're on hormone deprivation. So now we're not really in a recovery mode because you're still undergoing treatment, you know? So most men, when you're on ADT or Lupron shots, the Viagra, the Cialis, those pills are not gonna work. Because for those pills to work, your hormone has to be in balance, okay? So when your hormone level is low, it's more, when you take a pill, you're not gonna get the maximum response. So the only way for you to have an erection is generally with injections or surgery, okay? So I would not try the pills. I would consider doing either one of those two.
Yeah, it would seem to me that if you had radiation, whether it would be a proton or some other thing, that you would want to take your ADT, Lupron, or whatever, maybe a month or two before you started the treatment, and also keeping it into the, coincidentally, when you're on the radiation therapy. Did this fellow say that he's having the Lupron after he has the?
Yeah, so for most of the standard protocol is 6 months of ADT plus the radiation, standard radiation. Yeah, it's there's no, I mean, obviously every doctor has his own protocol, but the key thing is not necessarily timing. The key thing is that you combine two treatment options. So, but like I said, proton is a new high dose radiation. People are still figuring out what's the best way to use it, and they've been experimenting with different type of cancer, and prostate cancer is one of the things they're still learning.
I got it 21 years ago.
All right, let's go over here. Try it. I want to make one comment about the gabapentin or Neurontin. I've used it for quite a number of years to control hot flashes, and I have very few now. Okay. Anybody pass here? Yes.
Yep.
Doctor, in your surgery slide, you showed a penis that was fairly normal. Is it normal in older people that the penis shrinks? And is there a limit on penis size?
So the question's about size of the penis with surgery. So as you imagine, your prostate was part of your normal anatomy. So once they remove your prostate or they shrink your prostate, things are going to shrink, okay? When we remove the prostate, whether robotically or open surgery, there's two ends, the bladder and the urethra, we connect, right? So there's a gap. By reconnecting the gap, your penis is going to be at least 2 to 3 inches shorter, okay? That's just normal anatomy, right? If you remove something and you connect the two ends together, there's going to be lost size to start with. And the second thing is that most people don't get normal erections after treatment. Your penis also shrink because of it. The number one reason people is not happy after penile implant surgery is their size, okay? This is different than breast implant. A woman can go into a plastic surgeon's office, demand to be whatever size she wants to be. A plastic surgeon will make it happen. I cannot do that, okay? So through rehabilitation protocol, hopefully you will lose less size than you otherwise would have. But your erection with surgery will never be as big as your 18-year-old erection. People always compare themselves to their 18-year-old self, But if you have surgery, you will not. So basically what I do is that during surgery, we measure you internally, not just outside with a measuring tape, okay? People like Christy and then the medical devices, they will come and we have implants of various sizes. So we customize one that fits your body. If I put one in that's too big, you have problems. If I put in that's too small, you got problems too. So that's why we measure you. And so your size after surgery is not going to be smaller than your size before surgery. But unfortunately, it will not be when you're 18 either. That's why we try to help you generate your natural erection the best that we can, because that will always be bigger than your surgery erection, you know. But luckily, through the rehabilitation protocol, most men don't lose any more size. So even if you end up having surgery, you will get a functional result.
Okay, let me just ask you, you are also helpful in incontinence. Right? Want to say a few things about this?
Sure. So like I said, there was the 3 goals. One is the cancer control, that's number 1. Number 2 is not erection, it's urinary control. While we like to think sex is important, we probably have sex not as frequently as we go pee. You know, we gotta go pee every day. You probably don't need to have sex every day. Maybe some people do. And then the third thing is your erection. So the second priority is your urinary control, okay? It's important to do your Kegel exercises early, okay? Because that's the only thing during the rehabilitation process. I didn't put that in because that's not part of the sexual function, but when we see the guys, we also talk to them about Kegel exercises. For some reason, if I tell a woman to do Kegel exercise, they don't know how to do it properly. When I tell a guy to do Kegel exercises, they start doing abdominal crunches, they start squeezing their butt, they think that's Kegel, but all the women in the room knows that's not, okay? So the best feedback for doing Kegel or Kegel exercises properly is that when you go to the bathroom, midstream while you're peeing, you stop the stream, and then you pee again. That's the best feedback you have. Once you learn how to do that, then you do it while you're driving, you do it when you're watching TV, you're doing it during dinner, you can do that whenever you want, okay? In people who still have a hard time figuring out how to do it, we actually have pelvic floor physical therapists that actually can help you do feedback exercises to make sure you're doing it properly. Because we only have a year to get your urinary control back. So if you're leaking at 6 months, that's not a good sign. So when I check in with you with these milestones, we also check in with you on your urinary function recovery, okay? At 1 year, what you have is what you're gonna have, okay? If you have surgery and then you have radiation, for sure you're gonna leak, okay? Because that's 2 insults to your body beyond just 1, okay? But there are many things that we can do to help you with your urinary control, okay? It ranges from injections into the urethra to help you pee better, but that's usually short-lived. We also do sling surgery to help men with mild leakage. That's usually guys with 1 or 2 pads per day. In guys with more severe form of incontinence or have prior radiation, then we do what we call an artificial urinary sphincter surgery to recreate the muscle that's damaged to help you with urinary control. So unfortunately, most of the help after the healing process is done is usually a surgical procedure. But you do not need to wear a diaper for the rest of your life. There are a lot of things we can do, okay?
Since the same guy that invented the penal thing, invented
It's similar, yes.
Since we're talking about exercise, as far as testosterone level, exercise like going to the gym, walking, running, is that any way preventative as far as we age? Does our testosterone level go down because we're just more active?
Yeah, so the question about exercise and aging and testosterone. So exercise will slow down the aging process, but unfortunately, your body's not going to make more testosterone at age 70 than when you're at 40, okay? Even with how much exercise you have. You might just preserve it. You might just slow down the decline a little bit. The exercise will help with some of the side effect symptoms of the hot flashes and some of the ADT symptoms. So we usually tell guys to get on a pretty intense exercise regimen when you're doing ADT. But the problem is that you don't feel well. You know, when your hormone level is low, you don't want to go to the gym. You know, you're not motivated, you know, but exercise can definitely help you during your ADT period to help you mitigate some of those side effects.
Yes.
Is ITP feasible for a patient who's had brachytherapy, LDR?
Yes. So whether you have surgery, radiation, or on chemo, or on ADT, the penile implant surgery is available to all the guys, okay? The only time we had to choose difference is really for the incontinence, for the urine leakage treatment. Then we had to, then the radiation will preclude you from the sling procedure. You will need the sphincter procedure. But for the erection side of things, you know, it doesn't preclude you.
I'd like to, I was gonna call him, but he had a need to go down the hall here. On my buddy Bob, who's on intermittent for 20 years. He goes off his Lupron and lets his PSA rise, and he goes back on it and goes down, and he has been doing this for 20 years. He has his energy and enthusiasm, and this is another area that doesn't talk about intermittent in Southern California. Up in LA, they do.
Yeah, so I mean, I think it's changing. The attitude of how people take care of cancer, you know, is changing. Some people are what we call early adapters. They take on these new treatment protocols very early on with maybe less research. And some people are more conservative. They want to do the old school things until they want somebody else to. It's like, are you the guy going to buy the first model of the first new model of the car, or are you going to wait till a couple of years into it, then work out the kinks? You know, I would say LA is probably the people that's going to get the new car on day one, and then San Diego or Southern California, maybe people that we want to see them kind of see what they're like first before we get the year 2 or year 3 model. You know, so I think the medicine is no different. You know, some people, like, you know, at the university, we're a little bit more pushing the envelope, a little bit more maybe cutting edge, and some people might be say, well, let's let Dr. Mike do the crazy stuff first, and then we'll follow him if it works out, you know. So, but that's more personal preference and attitude.
Yeah, one question back there, sir.
So how do you approach the intermittent then with the testosterone? So if you did, say, 6 months or a year of ADT, would you immediately go with the testosterone for a year?
No, so most people on intermittent ADT, they don't have a testosterone. Well, their body can usually regenerate testosterone because they're only on it for a couple of months at a time, and then they live off their own hormones. So most of those men are not on testosterone replacement therapy. They're just on less ADT than the standard treatment protocol. So maybe 3 months a year they'll have low T, and then another 4 or 5 months they'll have normal T, living off their own hormone, and then once your PSA is not behaving anymore, they put them on ADT again for a period of time. So this is this up and down thing. So your body are always making a little bit on the background.
All right, 2 more questions. Yes.
What's the normal testosterone number? Is it dairy or?
So that's a good question. The question is about what's normal testosterone number. The short answer is I don't know. Okay, when you get a lab test, the lab is going to tell you normal is between 300 to 800. Why is this so? Why? Because we have no idea. Okay, we do know what low is. When you fall below 300 or 250, you're not going to feel good. Okay, but people always ask me, well, what should my number be? And unfortunately, I don't know, okay? If I draw a vial of blood in everybody in this room, women included, and I check your testosterone, biochemically, our hormones are all the same. But that same vial of blood, if I sequence your androgen receptor, we're all different. We all have different sensitivity, a different need for testosterone. You might see a guy, 90-year-old guy who's doing triathlons, and you're like, how does he do that? You know, his testosterone level must be really low because he's 90. But he doesn't need a lot of testosterone for your body to work. But in somebody else, I might see a man who's 35 years old who's having a hard time conceiving. Their testosterone level is 400, and he doesn't feel good, okay? So unfortunately, and I do research in androgen receptor at UCSD, but that's really more of a research thing than, I hope one day, when I check your testosterone level, not only I know it's high or low, I can also, based on your need, tell you what your normal is. But unfortunately, today, it's more of a trial and error. So your hormone's low, we put you on testosterone, and then we check your level again, and we check in with you. If you tell me that I feel great, and your blood test says 600, that's your number. Okay, so we're in a trial and error phase of testosterone, but one day, hopefully, we won't do that.
Yeah, blood pressure medication could be a cause of ED and also incontinence.
So the questions about blood pressure medicine, would it cause ED or incontinence? As I mentioned before, medications can give you side effects. Blood pressure medicine that lowers your blood pressure can also lower blood flow to your penis. So it's not uncommon. People say I was doing fine until I had a heart attack and my doctor put me on all these blood pressure pills and now I can't get an erection anymore. So those are the lowering blood pressure medicines. But if you have heart problems, doctors put you on something called Lasix or diuretics to help you pee a lot, get rid of the fluids that you can get rid of. That can worsen your incontinence because now you're going to the bathroom all the time instead of every 2 or 3 hours. So you're right, some medicine can affect your sexual function. Some medicine can affect your urination. That's why when we see the patients, we look at your medication list and we go over them with you. Well, I'm not going to take you off your heart medicine or your Lasix, but we will go over how to help you manage that.
Okay, that was the last question. Thank you very much.